Okay, I think we'll start now. I'd like to welcome everybody who's joined now our webinar hosted by the Education Committee of the Histiocyte Society. The topic today is the many faces of histiocytosis, decoding, diagnosis, dodging pitfalls, and mastering the mimics. Next slide. I'd like to just say a few words about the Histiocyte Society. We are a nonprofit group of over 250 physicians and scientists from around the globe, all committed to advancing the knowledge and improving outcomes for patients with histiocytic disorders. Our focus is on both clinical and basic research and also education. A few housekeeping messages. The participants are all muted. People who are interested in submitting comments can do so through the chat feature, which is at the bottom panel of your screens. And the chat will be you can see the control button, and we will be able to see it, and so will other people who are interested in looking at the messages. Questions for the speakers you can put in the Q&A box, and these will be addressed only at the end of both lectures. So please indicate to which lecture your question is aimed at. Please put the questions for staff in the chat box. Okay, and you can like a question in the Q&A box if your question has already been answered, and then we'll know that it doesn't need to be repeated. Due to some time constraints, we may not be able to answer all questions. We'd like to invite anybody who is on this webinar and not a member of the Histiocyte Society to become a member. It's a very, very active and vibrant society, and your involvement in the society will help us to find better treatments and hopefully cures for the various histiocytic disorders. You can also follow us on social media. As you see here, the QR codes for both X and LinkedIn. Okay. So I'm Joanne Jakubowicz, and I'm the chair of the Education Committee for the Histiocyte Society, and I'd like to present our two speakers today. First of all, Dr. Jen Picarsic, who's the chair of pediatric pathology at the University of Pittsburgh and UPMC Children's Hospital. She serves as a collaborator on many domestic and international projects focused on providing accurate and integrated pathology correlates to the molecular drivers of the rare histiocytic disorders for both children and adults. Dr. Picarsic is a co-author on International Histiocytosis Consensus Guidelines and numerous WHO classification of tumors chapters, while remaining active in the Society of Pediatric Pathology as a board of director member. And I'll say on a personal note that Dr. Picarsic is really the go-to person for all our complicated cases. Our second lecturer today is Dr. Aishwarya Ravindran, who is a consultant hematopathologist at the University of Alabama in Birmingham, UAB for the next part. After receiving her medical degree from Stanley Medical College in India, she pursued a research fellowship in hematology, followed by a pathology residency and hematopathology fellowship at the Mayo Clinic in Minnesota. Dr. Ravindran currently co-leads the histiocyte program at UAB with clinical hematology. Her academic research focuses on the phenotypic and genotypic correlates in histiocytic neoplasms and integration into clinical diagnosis. She has published numerous peer-reviewed scientific articles and was also a recipient of the Mayo Clinic Dr. Hobart K.B. Allenbach Fellowship Award and the American Society of Clinical Pathology 40 under 40 honoree for outstanding contributions to the field of pathology. So we're going to start with Dr. Picarsic.
Opposite. I think I'll be going first. Yeah, thank you so much, Joanne. Let me share my screen. All right. Good morning, everyone joining from the United States, and good afternoon and good evening to all participants from other countries. Thank you for joining us today. This webinar will primarily focus on the histopathology diagnosis of histiocytosis integrating practical insights from the lessons learned from our clinical practice over the years. So the primary learning objectives of today's presentation would include, number one is to understand the nomenclature of histiocytic neoplasms based on different classification systems currently. Number two is to characterize the phenotypic spectrum of histiocytic neoplasms. We'll be presenting a case-based approach to diagnosing these entities. And number three, to recognize the practical challenges of the scope because of the frequent overlap of these histiocytic neoplasms with normal benign reactive proliferations.
Aishu, you're not showing your slides.
Oh, I am not? Oh, let's see. I thought I was sure. Okay. How about now?
There we go.
Okay, great. Okay. So this is the first slide. So everything else was just theoretical. So I'm going to go ahead with this. So let's start with what are histiocytes. So when we talk about histiocytes, it's an umbrella term. It encompasses both tissue-resident macrophages and dendritic cells. And these are the immune cells derived from the mononuclear phagocyte system. The ontogeny of these histiocytes goes back to embryogenesis, starting from prior to birth, where the yolk sac and the fetal liver are your primary site of hematopoiesis. And these embryonic precursors give rise to the resident macrophages, which includes your epidermal Langerhans cells in the skin, the Kupffer cells in the liver, the microglial cells in the brain. These cells have a unique physiology in the sense that they're capable of constant self-renewal throughout the adult life, even after birth, independent of the bone marrow. But the key thing to remember is that the bone marrow is the primary site of hematopoiesis from birth throughout the rest of the life. But when there is a disturbance in the homeostasis, then they become they represent the primary site of production of this mononuclear phagocytic cells, giving rise to monocytic dendritic cell progenitors that differentiates into the monocytes. The monocytes, in the setting of infections and inflammatory conditions, they are the primary innate immune cells, giving rise to monocyte macrophages and monocyte dendritic cells. On the other hand, there is a common dendritic cell precursors, which gives rise to the classical dendritic cells, CDC1 and CDC2. They're primarily the antigen-presenting cells in the immune system, whereas the plasmacytoid dendritic cells are more robust in their antiviral immune defenses, and they're less potent in their antigen-presenting capabilities. It's important to understand this normal derivation of these immune cells, as these immune cells can have the potential to become neoplasms. And when they do, the key thing to note is that the cell of origin from which they derive, they take their name after, and we can employ the phenotype of this normal physiologic counterpart to diagnosing this neoplastic counterparts on tissue diagnostics. So based on the cell of origin, they could be giving rise to histiocytic macrophage neoplasms or classical dendritic and Langerhans cell neoplasms. Now, this plasmacytoid dendritic cell neoplasms, although they share the common ontogeny with the other histiocytic neoplasms, they have a completely different clinical cause and biology. The most common entity in this group is the blastic plasmacytoid dendritic cell neoplasms, which essentially behaves like acute leukemia. So they're really distinct compared to the clinical behavior of other histiocytic lesions. So talking about the mutational landscape in histiocytosis, over the past decade, we've known that the most common pathway involved in this pathogenesis of these histiocytic neoplasm is the mitogen-activated protein kinase, abbreviated as MAPK pathway. The most common mutation in Langerhans cell histiocytosis and Erdheim-Chester disease is the BRAF V600D mutation, followed by other KRAS and NRAS mutations. Whereas in Rosai-Dorfman disease, it's recent literature has shown the evidence of approximately 1/3 of these cases being clonal, with the most common mutations being KRAS, NRAS, and MAP2K1. And for this reason, the current classification system has recognized this as a distinct histiocytic neoplasms. Now, the other pathway is the phosphoinositide 3 kinase, abbreviated as the PI3K-AKT pathway. This pathway also is involved in approximately 10 to 20% of histiocytic cases, and it's important to sequence these histiocytic neoplasms for the reason being identifying these mutations will help us to treat them appropriately with targeted therapy with FDA-approved treatments available in the United States. Talking about the ERK pathway itself, when in majority of these neoplasms, given the MAPK involvement in the pathogenesis, there is sustained ERK activation, and this we can actually evaluate for this ERK activation by immunohistochemistry using phosphorylated ERK. It's called phosphorylation of ERK protein because it measures the activated kinase domain of the MAPK pathway and not the total ERK protein on the tissue neoplastic cells. So PERK is an IHC that we can employ in evaluating these histiocytic lesions, and sustained PERK activation leads to upregulation of transcription factors, which in turn causes the cyclin D1 gene transcription, resulting in overexpression of the cyclin D1 protein, something that we can apply for diagnosing histiocytic neoplasms and as well as distinguishing true neoplastic entities from reactive histiocytic proliferations. Coming to the classification, there are multiple classifications that currently exist. In the hematopoietic tumors, there are two different classifications that came out in 2022. There are three important distinctions and differences from the prior classification system. Number one, the WHO recognizes the plasmacytoid dendritic cell neoplasms under the category of histiocytosis because of the shared ontogeny with the other histiocytic neoplasms. However, the ICC does not include this entity under the histiocytosis, primarily because it has a different biology and clinical course, unlike other histiocytosis. The second important update is that the Rosai-Dorfman disease and ALK-positive histiocytosis have been recognized as distinct histiocytic neoplasms in these classification, which is a change from the prior WHO 2016 classification of hematopoietic tumors. The third distinction is this follicular dendritic cell tumors. They are derived from mesenchymal progenitor cells, and they are independent of bone marrow, unlike other histiocytic neoplasms. For this reason, the WHO has excluded this entity from the histiocytic classification category and has moved it to stromal neoplasms, whereas the ICC retains them under the histiocytic umbrella. The most comprehensive classification to date is the revised Histiocyte Society classification from 2016, which divides these several different categories of histiocytosis into 5 different buckets. Now, I have to emphasize the terminology here as disorders and not neoplasms, because not all these entities represent clonal neoplasms. Some of them are just like a spectrum of reactive benign proliferations, while others are more aggressive phenotypes. So going over to each bucket, the L group, all of these are neoplastic entities. They comprise of the Langerhans-cell histiocytosis, Erdheim-Chester disease, essentially systemic histiocytosis lesions. The C group, C as in cutaneous group of histiocytosis, this exists in a spectrum all the way from benign to neoplastic, and the neoplastic conditions in the C group can range from indolent behavior to all the way to aggressive phenotypes. The R group stands for the Rosai-Dorfman disease. M group stands for malignant histiocytosis. The upcoming new terminology is malignant histiocytic neoplasms. Now, the term malignant here refers to the aggressive appearing cytomorphologic features on histopathologic diagnosis, and also this malignant histiocytosis group clinically tends to be way more aggressive compared to the other histiocytic neoplasms. The H group stands for hemophagocytic lymphohistiocytosis. Now, this is an integration of clinical and laboratory criteria and not just a pathologic diagnosis. And this can be primary ways due to inherited mutations in pediatrics age group especially, or could be secondary, which you can see secondary to viral infections or lymphomas and other solid cancers, both in pediatrics and adults. For the purpose of this talk, HLH will not be discussed, but we will be discussing the remainder of the 4 groups. Now let's combine all the classification as to what is more relevant to the diagnosing pathologist. So in terms of integrating the 3 different classifications that exist, we can divide this broadly based on the immunophenotypes. The monocyte macrophage phenotypes includes these categories here based on the expression of immunostains, including CD68, CD163 with or without the presence of S100, OCT2, and factor 13A. Whereas the classical dendritic and Langerhans cells, I have to say, I call this as classical because the plasmacytoid dendritic cells and follicular dendritic cells are not part of the histiocytic neoplasm category. Hence the term classical dendritic cell to refer to the cell of origin based on the ontogeny. Now, this group is basically distinguished based on the presence of CD1A with or without Langerhans. The malignant histiocytic neoplasm is essentially has an overlap of both monocyte macrophage and classical dendritic and Langerhans cell phenotypes. In majority of these neoplasms, as discussed before, they usually harbor the MAPK pathway mutations followed by the PI3K AKT pathway. Rarely, in about 10 to 20% cases, you hardly find any mutations in these disorders. So for the session 1, which will be the discussion in my session, would include all of these different entities in the monocyte macrophage phenotypes. And the session 2, which will be led by Dr. Picarsic, will include the malignant histiocytosis and the dendritic and Langerhans cell neoplasms. So case-based approach, going to case number 1. Now, this is a 60-year-old male who presented with left carotid artery stenosis and underwent a carotid endarterectomy. Typically, when you have carotid stenosis in an elderly adult, the most common diagnosis, even before pathology review, is going to be atherosclerosis. When you have atherosclerosis, the morphology correlate would be the presence of cholesterol clefts. But in this, unlike in this case, where there were sheets of histiocytes in the wall of the carotid artery, there was no cholesterol clefts present, and these histiocytes were diffusely positive for CD163 and S100. Morphologically, this is a case of Rosai-Dorfman disease that was involving the carotid artery. Now, RDD diagnosis is primarily a histopathologic diagnosis characterized by this ovoid nuclei with small conspicuous nucleoli and abundant cytoplasm. They could be foamy cytoplasm or they could be pale eosinophilic cytoplasm with frequent engulfment of inflammatory cells, most commonly small mature lymphocytes, plasma cells, and sometimes neutrophils. Now, this is a phenomenon called emperipoiesis. Emperipoiesis, while it's frequent in Rosai-Dorfman disease, it is not pathognomic of Rosai-Dorfman disease, as it can be observed in reactive histiocytic proliferations as well as in other histiocytic neoplasms. But in terms of the phenotype, this is positive for CD163. CD163 can be negative in approximately 10% of Rosai-Dorfman disease. Hence, it's very important to at least do 2 or more histiocytic lineage markers like CD68, PU.1 in order to ensure the right lineage classification. The other phenotypes in RDD includes the positivity for S100, OCT2. OCT2 also stains background small B cells and plasma cells. So when you're interpreting it, it's necessary to know that necessary to interpret this OCT2 expression in this large lesional cells of interest. Now, cyclin D1, as I indicated before, because of the underlying MAPK path or presumed underlying MAPK pathway activation, you see this overexpression of cyclin D1 protein in majority of the RDD cells. Cyclin D1 expression doesn't necessarily mean the patient has a MAPK pathway mutation. It just means there is a presumed underlying activation with or without the presence of MAPK pathway mutations. Just like in our case where it was involving the carotid artery, RDD can involve any organ site. Historically, is known to be more popular in the nodal sites, especially when it was initially described in pediatrics. But contemporary data, especially in adult histiocytosis population, shows that extranodal is as common as nodal site, and the most common extranodal site of involvement is skin. And some of the other pointers that I want to bring up is that RDD can overlap with ECD phenotypes, especially when it involves a retroperitoneum presenting as perinephric thickening. And it can also mimic LCH, Langerhans cell histiocytosis phenotype. When it presents in the bone, it manifests usually as osteolytic lesions. While majority of the cases of Rosai-Dorfman disease are typically sporadic in nature, there is a minor proportion of cases which can have a familial predisposition. This specifically could be seen in Asian and North African ancestry. And when the patient usually presents at a younger age and it's a family history of Rosai-Dorfman disease, it's helpful to evaluate for this specific mutation SLC29A3, which is not really covered in the most commercial NGS panels and needs to be specifically sequenced separately in suspected familial cases. Rosai-Dorfman disease can also associate with a lot of conditions, including lymphomas, autoimmune diseases, and as well as other histiocytic neoplasms. Now, in terms of semantic wise, emperipoiesis is just a cell passing through another cell. You see this even commonly in megakaryocytes in the bone marrow, where oftentimes white blood cells are just present in the cytoplasm of a megakaryocyte. This is different from hemophagocytosis, where the macrophage destroys the blood cells. Here you can see this erythroid precursor, nucleated erythroid precursors here, as well as nucleate white blood cells, which can be destroyed by the macrophages, and that usually manifests as cytopenia. Hemophagocytosis is only one of the 8 other criteria for diagnosing hemophagocytic lymphohistiocytosis, and this can be present in patients with and without HLH. So in terms of BRAF V600E mutation in Rosai-Dorfman disease, unlike Langerhans cell histiocytosis and Erdheim-Chester disease, this is an extremely rare finding in Rosai-Dorfman disease. And when you find this BRAF V600E positivity by immunohistochemistry, it's always important to confirm by digital droplet PCR or by NGS sequencing. And when you do, something to keep in mind is that BRAF mutation in Rosai-Dorfman disease can be a spectrum of mixed histiocytosis. Mixed histiocytosis means the presentation of 2 or more histiocytic neoplasms in the patient, either at the same site or at different sites at the same point in time or at different points in time. The key thing to note is that most of the times, greater than 95% of these cases are driven by this driver mutations, and they respond well to targeted therapy compared to conventional chemotherapy. Sometimes you can see collision tumor, that is RDD in one aspect of the same tissue, whereas Langerhans cell histiocytosis in other part of the same tissue site, in which case a mixed histiocytosis diagnosis could be rendered on histopathology. But more often than not, they are a clinical integration of diagnosis, because a patient can have LCH 20 years ago, but now presents with Erdheim-Chester disease or vice versa. So it essentially relies on the clinical coordinating management team to put together the diagnosis of mixed histiocytosis when the history presents years apart. Case number 2, this is a 30-year-old male who presented with progressive bilateral diplopia for over 2 years. MRI revealed a T2 hypointense lesion, which was highly suggestive of meningioma. But biopsy showed this kind of mixed inflammatory infiltrate composed of this histiocytoid cells, some small mature lymphocytes, eosinophils. So it was characterized initially as lymphoplasmacytic and histiocytic infiltrates, and negative for meningioma, lymphoma, and other nerve sheath tumors. However, given the histiocytic infiltrates presenting like a mass-like lesion, the question was, could this be histiocytic neoplasm? The most common thing that mimics a meningioma and histiocytosis is Rosai-Dorfman disease. So the workup panel revealed S100 expression and cyclin D1. You can even see the cyclin D1 demonstrating emperipoiesis in this histiocyte showing strong cyclin D1 expression. However, OCT2 is negative. OCT2 is typically positive in over 95% of Rosai-Dorfman disease cases, but when OCT2 is negative, you also have to think about, could this be something else? So on further workup, these cells show diffuse cytoplasmic ALK immunoreactivity. And interestingly, FISH was negative for ALK gene rearrangement, but RNA sequencing was positive for ALK fusion. This was a case of ALK positive histiocytosis, which is a recently recognized entity in the classification defined by the presence of ALK gene translocation. Now, the negativity by FISH could be 2 reasons. One, the sparsity of the tumor cells, it could be very few. Number 2, the technical cutoff for FISH for ALK gene rearrangement in histiocytic lesions is not really well established, unlike well-established criteria in lymphomas and lung cancers. So you want it in general, RNA sequencing is preferred over FISH if you have the if you have the ability to do sequencing. But it has to be kept in mind the ALK immunoreactivity in these histiocytes are typically never nuclear. They're usually cytoplasmic, could be membranous, or could be Golgi-like staining. The key thing in terms of the clinical course, they show a great response to ALK inhibitors, but clinically they can also mimic Rosai-Dorfman disease. Just like in this case, histopathologically, it was mimicking a Rosai-Dorfman disease, but it can also mimic an Erdheim-Chester disease like phenotype, where the defining diagnosis lies on identification of this ALK gene translocation or fusion by RNA sequencing. This is another case alongside the ALK immunoreactivity and the practical challenges we face and daily diagnostic practice is that the ALK immunostain here in this particular case was staining a lot of histiocytes, but the histiocytes were negative for ALK gene rearrangement by both FISH as well as RNA sequencing and did not show any abnormal phenotype, unlike the last case. Here it was completely negative for S100, cyclin D1, and factor 13A. This was a patient who had a breast biopsy and there was an incidental finding of sheets of histiocytes. There was no prior history of any trauma that could result in fat necrosis, no prior history of any chemotherapy that could result in histiocyte-rich pseudotumor. So essentially, we were just characterizing this histiocytes and then found this kind of ALK immunoreactivity. On repeating with a different clone, the D5 clone, which is the most sensitive clone, but it can also cause some diagnostic challenges, which I will talk about in the upcoming slides. The D5 clone showed this nuclear expression, unlike the 5A4 clone, which predominantly showed only cytoplasmic expression. However, it was negative for all the sequencing. So this was not diagnostic of ALK-positive histiocytosis. Let's put a pause on this case and I'll come back because I want to bring up a discussion on a recent study. A recent study by the French group showed that about 21% of patients with histiocytic neoplasms had this nuclear and cytoplasmic expression of ALK by immunohistochemistry, but these were negative for ALK fusions. And they identified the presence of ALK ATI isoform, the ATI being alternative transcription initiation. This isoform was identified on intron 19 sequencing, and this has been established in melanoma previously, but it's never been shown in histiocytic neoplasms. So hence, this paper is it's really important to understand the spectrum of ALK immunohistochemistry in diagnostics. But in this particular case, they were established cases of histiocytic neoplasms, and you had an RNA expression showing an abnormal ALK ATI isoform, suggestive of some alternative mechanism of ALK upregulation by immunohistochemistry, and there could be potential for treatment with ALK inhibitors in in histiocytic neoplasm with ALK expression, but without ALK fusions. Now, going back to our case where there was ALK expression by two different antibody clones with D5 showing nuclear expression, the intron 19 was analyzed and there was no expression present on intron 19. This area is between the exon 19 and exon 20. Hence, this was just a case of ALK immunoreactive histiocytes of unclear significance, and it's not diagnostic of ALK-positive histiocytosis. In daily practice, one thing to keep in mind is that the D5 clone is extremely sensitive and it can non-specifically stain reactive histiocytic proliferations. But hence, it's usually preferred to use other clones other than the D5, such as 5A4 clone or OTI 1A4 clones. But when you have some ALK immunoreactivity in other clones as well, in the absence of RNA sequencing demonstrating abnormal clonal rearrangements or abnormal clonality by negative for intron 19 expression, it's okay to be descriptive when you sign out these cases because they are not diagnostic of a true histiocytic neoplasm, but we certainly don't know what is causing this ALK immunoreactivity in these other histiocytes by clones other than D5. So there is the other entity that was just recently described by two different case series that came out about the N-track rearranged histiocytosis. This is very similar to ALK-positive histiocytosis, except that in this case, you find this N-track gene rearrangement by fish or actually RNA sequencing studies. They also have a great potential to respond to track inhibitors, even in multisystemic involved cases. So similar to ALK-positive histiocytosis, this should essentially be diagnosed based on the presence of N-track gene arrangements by molecular analysis, but immunohistochemistry you can employ pan-track to identify this expression in this histiocytes. We still have to explore if there is any fallacies in pan-track expression like we observed in ALK, but to date, in order to diagnose an entity of N-track rearranged histiocytosis, it's always preferred that you use RNA sequencing or FISH for confirmation. So case number 3, this is a patient in mid-50s presenting with bilateral proptosis, eye irritation, and ophthalmoplegia. And you can see this bilateral intracronal involvement by some of this infiltrative disease. And the patient was initially started on steroids, but did not really respond well. So subsequently, an orbital biopsy was done. And as you can see here, you see this sheets of foamy histiocytes in this area here. So whenever you see sheets of foamy histiocytes, the most common differential being should be infections. So you have to evaluate for mycobacteria and fungal organisms, which was negative in this particular case. It was also negative for lymphoma because in orbital infiltration, the most common differential is SMALT lymphoma. And the third most common differential being the IgG4 related disease, which was also negative here. As you can see, is only sheets of foamy histiocytes with no increase in plasma cells, essentially. So the patient was initially diagnosed as xanthogranuloma and went on for at least 5-6 months without having any response to treatment. She had some transient response to treatment, but eventually kind of came back with progressive symptoms. Eventually, a PET CT was performed because of the xanthogranulomatous nature of the biopsy, which showed this right atrial cardiac mass, some perinephric thickening, as well as bilateral bony osteosclerosis. Radiologically, this combination is typically seen in a histiocytic neoplasm, specifically Erdheim-Chester disease. And on re-evaluation of this pathology, we identified these histiocytes with diffusely positive for cyclin D1 and BRAF V600D, which was also confirmed by molecular analysis showing this BRAF V600D mutation. This was a case of Erdheim-Chester disease that was mimicking a benign xanthogranuloma. And on further follow-up, the patient was treated with MEK inhibitor and BRAF inhibitor as a combination therapy. And you can see this remarkable response in these bilateral orbits that shows like complete resolution of this infiltration that was present at diagnosis. So diagnosing Erdheim-Chester disease, by far this amongst the other histiocytic neoplasm, this is the most challenging diagnosis to make just on histopathology. It always requires a clinical, pathologic, as well as radiologic correlation. The classic pathognomic findings of ECD include this bilateral bony osteosclerosis, skin lesions. If present, they present as periorbital xanthelasmas, but they can also present as xanthelasma elsewhere in the body as well. Hairy kidney refers to this perinephric bilateral perinephric thickening secondary to histiocytic infiltrates in this region. The right atrial mass, as shown in our case, it's just a pseudotumor, but the pseudotumor is composed of neoplastic histiocytes in the right atrium. We don't know what really causes the predilection to the right atrium, especially in ECD patients, but it's just that the nature of this disease combination that usually it has right atrial mass in approximately 40 to 50% of cases. The coated aorta refers to the periaortic thickening by this neoplastic infiltrates, and pituitary and cerebral lesions can also occur in approximately 1/3 of cases. With diabetes insipidus can precede a diagnosis of ECD by several years. I think the longest I've seen is 10 years of diabetes insipidus prior to a diagnosis of Erdheim-Chester disease being made. In terms of histopathology, there are no pathognomic marker for ECD diagnosis, unlike those that you see in Rosai-Dorfman disease or Langerhans cell histiocytosis, because they also mimic reactive histiocytic proliferations. But we know that BRAF mutation is present in 50 to 60% cases of Erdheim-Chester disease. Therefore, you can actually routinely employ the BRAF immunohistochemistry to ensure we're not dealing with the neoplastic histiocytic proliferations. But in cases that are BRAF negative, then again, we are back to the question, like, how do we differentiate from reactive histiocytic proliferations? A recent study showed the expression of cyclin D1 being present in over 90% cases of Erdheim-Chester disease. This pattern of cyclin D1 refers to this diffuse, uniform, strong expression with weak blush cytoplasmic expression in these histiocytes. This pattern is typically absent in reactive histiocytic proliferations, or rather, I would say, if reactive histiocytic proliferations have the cyclin D1 expression, they're typically weak or negligible in less than 5% of the total reactive histiocytes. Unlike in neoplastic histiocytic proliferation, the entire diffuse histiocyte proliferation typically shows this overexpression of cyclin D1. And genetic alterations, it's typically MAPK pathway in 70 to 80% of cases. There's also recent evidence that shows the presence of CHIP mutations, which are the TET2, ASXL1, DNMT3A, which is present in approximately 40% of patients with Erdheim-Chester disease, and they are associated with myeloid neoplasm in approximately 10 to 15% of cases. In terms of PERK expression, we acknowledge that PERK is not really widely available immunostain. In fact, I don't have the stain in my current practice. But something to note is that PERK expression can be present in histiocytic neoplasm, but it's not always in sync with cyclin D1 positivity. But interpretation of PERK can also be challenging because it can also stain a lot of background cells, including endothelial cells and fibroblasts. There is potential for false positive interpretation. Hence, it's always necessary we employ a panel of diagnostic immunostains prior to diagnosing a true histiocytic neoplastic component. And it's always recommended you also pair it up with next generation sequencing, especially when you're dealing with a case of suspected Erdheim-Chester disease. So last case number 4 in this group of monocyte macrophage phenotype. This is a patient with multiple skin lesions. You can see here this multinucleated cell. This is what we call as Teuton type giant cells in a background of spindle to epithelioid histiocytic proliferations, which showed this diffuse expression of a dermal macrophage phenotype characterized by CD163, factor 13A expression, had some variable cyclin D1 expression and diffuse expression of S100. Now, diffuse expression of S100 can be seen in this case of xanthogranuloma. It doesn't necessarily mean as Rosai-Dorfman disease. The morphologic distinction is what makes the distinction between Rosai-Dorfman disease and xanthogranuloma. In this particular case, depending upon the age, it's all a play of semantics. In pediatric age group, this is what we call as JXG phenotype, whereas in adults, we could say this is an adult onset XG. The key thing to note is the xanthogranuloma family of histiocytic lesions and has some abnormal IHCs, as you can see here. But the important thing clinically needs to be the distinction from Erdheim-Chester disease. Pathologically, we cannot distinguish ECD from XG family of lesions, and it relies heavily on radiology. So in this particular case, PET-CT was completely negative for systemic involvement, but you can see here the patient had multiple skin lesions. Interestingly, was found to have a FLT3 fusion, which showed a remarkable response to sorafenib. Sorafenib has a wider range of response against FLT3 variants. Hence, that was used in this particular case. And you can see this distinction at follow-up 6 months showed near complete response to sorafenib therapy in the setting of a FLT3 fusion. This was a case of multiple adult onset xanthogranuloma that overlaps with Erdheim-Chester disease. And this image shows the variant morphologic patterns that you can see across both the disorders, including some xanthomatous spindle histiocytes without Teuton giant cells, or the sheets of foamy histiocytes with Teuton type giant cells. And other variants include this epithelioid cellular cytology, epithelioid ovoid histiocytes with absent Teuton type giant cells. Sometimes they can have more atypical features than what you observe in the foamy histiocytic cytology. And reticular histiocytoma cytology is characterized by this glassy eosinophilic cytoplasm. And this also needs to be distinguished from if this is a solitary reticular histiocytoma, a multicentric reticular histiocytoma. They are all other variants of the XG family of lesions, but the key correlation becomes the PET-CT finding of systemic pathognomic ECD findings, if present, would distinguish true ECD from other XG family of lesions. So some practical insights into xanthomatous and xanthogranulomatous morphology is that all of these entities shown here can have this overlapping phenotypes. But the key distinction comes in terms of PET-CT showing this pathognomic radiology features in ECD, which is absent in JXG, XG type of lesions. ALK histiocytosis can mimic ECD phenotype, but the key distinction comes by molecular presence of this ALK fusion or ALK gene arrangement, and so is NTRK rearranged histiocytosis, which can also mimic a ECD phenotype, but is defined by this NTRK gene arrangement or NTRK fusions. This is a summary slide depicting the phenotypes across the various monocyte macrophage neoplasms as well as the dendritic cell neoplasms here. Some key highlights here: ECD, JXG, AXG should be, the distinction should be made by clinical and radiology. But there's Rosai-Dorfman disease, typically positive for S100 and OCT2. ALK and NTRK, I would just not diagnose this based on IHC alone. It's always good to do NGS and confirm the presence of either gene arrangements or fusions by RNA sequencing or FISH. The dendritic and Langerhans cell phenotypes are defined by the presence of CD1A with or without Langerhans, which will be discussed in the next session. So final slide, as a take-home message, not all histiocytes are histiocytic neoplasms. You can see the xanthomatous histiocytes or xanthogranulomatous histiocytic proliferations on histopathology in a variety of reactive causes, including the most common being infection and inflammatory etiologies. In skin, the most common being a spectrum of inflammatory dermatosis. The other differential diagnosis to be considered would be metabolic xanthomas, such as dyslipidemias, fat necrosis, necrobiotic xanthogranulomas, and histiocyte-rich pseudotumor. This is an entity we typically see, at least in the hematopathology side, in patients with lymphoma. After they undergo therapy, they present with a PET avid lesion. When you biopsy the PET avid lesion, they're usually composed of this histiocyte-rich pseudotumor, and they are not true histiocytic neoplasms. So on that note, I will conclude my session and I will pass it on to session 2 to Dr. Picarsic. Thank you all.
Thank you. All right. Can you hear and see my slides?
Yes, we can see it.
Okay. Sounds good. All right. So in this whirlwind, we are going to step in now to the L and M group that was previously sort of discussed. And within that group, we'll touch on a few cases highlighting the spectrum of LCH, indeterminate cell histiocytosis, and some new ideas, especially in pediatric cases of maybe this mixed BRAF histiocytosis. And then we'll round out this newer sort of terminology of the alphabet soup of the M group lesions. So as was discussed, it's important to remember that a histiocyte is not a single cell type. It's this umbrella term we use for the mononuclear phagocyte system. And then knowing within histiocytosis or the histiocytic neoplasms that these are mutated. So while they somewhat recapitulate the de novo tissue cells, there are some variations given when those mutations occur. So just remember that this is an umbrella term. So it's been nearly 40 years since the original classification grouping, and while things have changed, there's still basically these three major groups of the LCH, non-LCH, and malignant neoplasms. But as was discussed, this understanding of the L group is really important because while we know that LCH is more of this dendritic and ECD is more macrophage-ish, they share a common mutation. And we'll see that, in adults, we can have mixed histiocytosis, but it's probably a little bit more common in pediatrics than we fully realize of this spectrum, specifically in BRAF mutated cases. We'll highlight a few of those cases upcoming. And then in the M group, sort of, again, to understand that once you hit that threshold of malignancy, it's within a different category as compared to these others. And sort of the main point is to get it into this category rather than trying to always subclassify the type. So for pathologists, it's very important to know that not every collection, right, of tissue histiocytes are actually histiocytosis or the neoplastic form. In various entities, we'll see these collections, and that's always the conundrum, is this really neoplastic or not? So we'll go over a few of these mimics, especially within the L group. This one being a very classic one, and I show this sort of picture in all of my lectures because it helps to see them sort of side by side. So, it's very common to get this in consultation. Is this LCH? We have an enlarged lymph node. There may be an associated rash. And actually, this is a mimic. So when you're looking at sort of the features, we have a thin capsule here as opposed to a little thicker capsule. The paracortex is greatly expanded here with the CD1A and longer and positive cells, but they're in the paracortex, and really the sinus is compressed. You can see the different compression of the sinuses, and this is mostly a paracortical expansion, as opposed to the true LCH case where this is a sinus expansion, and then there is some overlap into the paracortex, but you can see the nice retained follicles, and you can even demonstrate, even sometimes on a CD20 stain, those B cells still compressed up against the capsule. You'll always see one or two CD1A and longer and positive cells in the sinus because they're translocating through, but it's knowing that sort of pattern and distinction that will save you from getting into trouble. Okay, so our first case in the L group, this was a 14-month-old female. She had multi-system LCH, not in any of the so-called risk organs, so it wasn't in the bone marrow, liver, spleen, but there was a classic presentation with these sort of coffee bean type nuclei. There were some eosinophils in the background, nice strong longerin or CD207 as well as CD1A. CD163 highlighted a few cells, but mostly negative. The mutant-specific BRAF VE1 immunostain was a little on the light side for my liking, but this was a consult case, and it was confirmed with the mutation. So this was real staining. And so the patient was started on LCH4-based therapy for a year and seemed to do well, but a couple months after the end of therapy developed this yellow nodule on the upper back, which was unusual, and that was biopsied. And there were a few in the background, sort of more classic LCH type cells. There were some eosinophils scattered around, but there were these large cells, and as was previously described, we would probably call these more of reticulohistiocytoma-like cells with this glassy cytoplasm and large nucleus. And I consider those within that spectrum of the xanthogranuloma family. Those large cells were positive for CD163 and the factor 13A. Interestingly, they were S100 positive, which sometimes, as was discussed, especially for those ones with the reticulohistiocytoma, they can have some S100 staining. But knowing this history of LCH and the CD1A and longerin were done, there were definitely clusters of CD1A, but longerin was pretty much negative. So now you're in a conundrum as a pathologist. You had LCH. Now it looks like there's xanthogranuloma. Is this indeterminate cell histiocytosis? So we did perform the BRAF staining. And again, it was positive strongly, both in these larger cells and some of the background smaller cells. So, this would be what I would consider in this L group, despite having a pediatric case. So, there's many different ways in which to call this. You could be very specific in calling this sort of a xanthogranuloma family. Technically, it is an indeterminate cell histiocytosis without any longerin expression, but it was following a patient that was treated and originally diagnosed as LCH. So, I put all of this in the comment, but typically for my diagnostic line, I'll call this as a BRAF mutated histiocytosis for the clarity of knowing that this is still an active histiocytosis, of course, with this mixed phenotype. And I think this also brings up the important point that in kids, pediatric ECD is exceedingly rare. But in cases like this, I think it's still it lends itself to the fact that yes, you do need to make sure that there's not clinical radiographic features similar to adult ECD. Oftentimes there's not. So I put that always in the comment, but this is an entity that we're seeing a little more frequently now that we're staining these and doing more molecular diagnoses. A somewhat similar case of a 4-year-old male. He had multiple lytic bone lesions, an orbital lesion. They tried to biopsy, weren't able to see the CD1A and longer in cells, but knowing the sort of clinical radiographic appearance, they did decide to start treatment for a year with this child. I never saw the original biopsies, but about after therapy, after having a good initial response, there were still multiple bony lesions as well as a soft tissue lesion that was biopsied. And that soft tissue lesion was very interesting. It was very xanthomatous. Some areas showing more classic Teuton giant cells in a background of other foamy histiocytes. Small pockets, though, had smaller intermixed cells. And when we did the immunohistochemistry, it did show that there were areas with CD1A and longer in positivity, some other areas with S100. The pattern was a little strange. There were small cells staining with CD1A and longerin, but even some of the larger xanthomatous cells had this accentuation of longerin. The foamy cells had a variable light S100 staining. And another interesting aspect that while factor 13A was largely negative, the CD163 was diffusely positive with the typical surface staining, but it also had this interesting, more Golgi accentuation that we sometimes see more often with CD68, showing a sort of dendritic cell pattern with this paranuclear Golgi type staining. So that was an interesting additional feature in this case. And all of these foamy xanthomatous histiocytes were also positive for the mutant-specific BRAF VE1 immunostain. So again, these challenges, what are we going to call this? There's multiple choose your own adventure of, what classically, mixed histiocytosis. It has this LCH and somewhat Erdheim-Chester disease look, but again, in a child, that'd be very unusual. Most typical JXGs do not have BRAF mutation. So again, we're in this sort of mixed histiocytosis. Definitely would never call something like this burnout LCH, knowing that there's mutation in both populations. So I typically would call this as, again, a BRAF mutated histiocytosis with the understanding that, again, it has this mixed phenotype, and that really it's the driver mutation that we should be focused on, more importantly for the treating physician, right, as opposed to that phenotype. I think it's really important as we progress to continue to require and think about getting tissue biopsies for relapses to really understand this pathophysiology a little bit better. In all of these cases, I get my immunohistochemistry as well as NGS to further characterize this. So we're seeing this more in children, that this, especially with knowing having an LCH first and then this more xanthogranulomatous look. So whatever you do, don't let your pathologist call this as burnt out LCH, never with foamy macrophages. Maybe prior to 2010 when we didn't know that these were mutated, but these are very important to know the mutational status. So again, could you call this xanthogranuloma family and LCH? Yes, that's perfectly fine. I tend to keep it a little more simplistic for the diagnostic line and then further explain in the note, with, again, making sure that pediatric ECD is excluded. So I think these cases bring up an important point of trying to understand sort of what this contribution, especially of this BRAF mutated population with the CD163 phenotype has. You'll see cases that the CD1A and longerin are completely gone with this population. And this might be the clue as we're trying to understand and how to cure these children. We've seen these aggregates in neurodegenerative brain lesion at autopsy. We've seen this now at explant with kids having LCH within the liver bile ducts, especially when it's sort of accumulated and causing obstructive changes in the bile ducts with the CD163 VE1 positive cells. Also in the bone marrow of kids that even clinically seem to be cured, but still have this mutant population in their bone marrow. So Carolyn Hooder's group, I still love always showing this figure because it really sort of helps to understand that we've focused so long on the tip of the iceberg, but sort of understanding this mutant population is really where future cures will probably lie, as we understand that LCH is not just CD1A 207 cells, but there's so many different subtypes within this population of mutated cells that can be the progenitors, the maturing versus the destructive, and trying to understand sort of what subtypes of these cells will then go on to maybe change their phenotype and be more resistant to treatment is really the holy grail as we progress in the next decade of LCH discovery. We're starting to see this with being able to do more testing for understanding, what is in the blood of these patients. So typically in the past, we thought about, sorry, to mute this. We've thought about LCH within high risk disease based on a survival based model, but now we're starting to understand that some of these children with so-called low risk or risk organ negative LCH will still have a propensity for treatment failure and neurodegeneration. And maybe by looking in the blood and bone marrow of these children and seeing that there is BRAF positivity, we'll be able to refine and redefine what is high-risk LCH in the future. All right, so just switching gears to our indeterminate cell histiocytosis. There can be different acronyms, so just so you know, both of these mean the same. So there has been two nice recent studies that we'll briefly highlight, going into more depth about the characterization of indeterminate cell histiocytosis. But often in adults, this is more cutaneous-based disease. It was originally described with the ETV3 fusion, but we're realizing that many of these cases, even more so, have MAP kinase pathway mutations. It's really important in these, especially in adults, to rule out previous or concurrent hematopoietic malignancies, especially cutaneous lymphomas. And a word of caution, though, for children, in that as we ask more and more for pathologists to do both CD1A and longerin or CD207, it's important to know that for kids, basically with any longerin expression, I like to keep this within the LCH family. I think there is a slight difference between children and adults, and even in some of these studies where they showed lower, longerin expression, they were treated as LCH, responded as LCH. There's also more frequent BRAF mutation in kids with this. So really, if there's any longerin expression at all, I would keep it more as LCH for kids. But as we look more in depth at some of these from the Ozakaya et al. And the French and NIH group, they really showed there was a large percentage of these with a concurrent lymphoid or myeloid neoplasm, and they really did worse than the ones that were sort of de novo. So whether it's based on the shared clonality knowing that, some of these can have a little bit more atypical look to them, a sort of borderline, in some of these cases with a malignant histiocytic counterpart to these. But it's important to always recognize, especially in adults, whether it's associated with another hematopoietic neoplasm. And the group in the Netherlands, led by Paul Kemps, also showed some similar features, a little fewer cases, but again, associated with an additional hematologic cancer was quite prevalent, along with the association of some of these CHIP or epigenetic regulator mutations, which was a higher frequency than what we would expect in other LCH and ECD. All right, so we have our second mimic here. Now, how many would call this indeterminate cell histiocytosis? I mean, we have histiocytes, they're CD1A positive, longer and negative, but it's important, again, with skin to know the pattern of involvement. So this is a much more perivascular infiltrate. You can tell that there's histiocytes. It's a pinkish, look. There's ample cytoplasm, but it's really hard to see the exact cell type. And when we stain this, it has this more dendritic or spindled population. It doesn't have this epidermotropic pattern. And even in indeterminate cell histiocytosis, it basically should still have the pattern of LCH and filling up that upper dermis. So this is actually a case of reactive dermatosis. Dendritic cell hyperplasia can be quite frequent in different chronic dermatitis, especially with scabies and other inflammatory conditions. And it's one of the sort of soft cues also for this, that if you have this spindled cell population of CD1A and low or negative longerin in this perivascular distribution, it helps to show that this is a reactive population. Okay, so moving on to this last group of our alphabet soup of the M group. So this is a case that we had presented back in 2021 at one of the Society for Hemopath conferences. And I think it's a nice example to recapitulate all of this. So this was a 4-year-old who had a ALL diagnosis from a lymph node biopsy. His marrow and CSF was negative, but he went through treatment, completed good radiographic response, completed therapy without any complication, and then 10 months after therapy, started to develop some skin lesions in addition to some lymphadenopathy, a bone lesion, which was unusual. They did biopsy one of the skin lesions, which showed LCH. At the time, they also went back and re-biopsied the marrow, which was negative for both LCH and the T leukemia. Systemic therapy was started, and there was an initial good response to the lesions that had popped up. But about 4 to 6 months into therapy, these lesions not only came back, they started to enlarge. So therapy was changed and added cytarabine, but the lesions kept increasing, and it became so large that it was starting to become somewhat disfiguring. I mean, this is a large 12-centimeter lesion with these multiple ulcerated areas. This isn't sort of typical for LCH. These pictures are a little old and blurry, but just to recapitulate again, LCH basically is this more dermal, epidermotropic. Sometimes with like a newborn, you'll get a deeper lesion, but to have a expansile lesion going into the deep subcutaneous is very unusual for LCH, wrapping around some nerves and then blood vessels. And as you scanned around in some of the different areas with the sheet-like infiltrate, the cells starting to look a little atypical, getting a little bit larger, a little more hyperchromatic, somewhat losing that nice reniform typical appearance, mitoses that are getting little on the atypical side. And then there were areas within the same lesion of more frank malignant anaplastic appearance with necrosis. The immunophenotype was still consistent with that Langerhans cell CD1A and Langerhans positivity. There was very high Ki67. TDT, of course, was negative, although interestingly, there was a small pocket with CD34 and CD3 positivity, and then loss of P16. So that loss of P16 correlated with the copy number loss at the CDKN2A / B locus. And in addition to those copy number changes, there was also additional mutations. So not only was there similar mutation in the Notch and NRAS as the original leukemia, but there were additional non-V600E BRAF mutations that were also detected. So, what are we going to call this on the diagnostic line, right? So these are the cases that I would label as a secondary malignant histiocytic neoplasm of the Langerhans cell sarcoma type. So even though the original biopsy looked more like LCH, and then in the subsequent resection, you had areas both of sort of this lower and higher grade cytomorphology, we would go by the highest grade and sort of this infiltrative growth pattern, as well as the additional molecular alterations. This original paper back in 2010, sometimes it's hard to find this being in the pediatric and developmental pathology, but my late colleague Ron Chaffee had a nice characterization of over 15 cases of these histiocytic neoplasms that occurred after leukemia in children. And there was a very similar case to this, a patient that had a T-ALL that originally presented with LCH and then subsequently developed a Langerhans cell sarcoma look. So this brings up this challenging idea of, what do we call these that look, whether they look sort of more like a run-of-the-mill histiocytic neoplasm, or if they look malignant, like what should we call these when they're occurring after a hematopoietic malignancy, especially the ALLs in children. So I first, consider what is the cytomorphology. If this looks malignant, then we're going to call it as such. It's the cases that don't yet look malignant that still concern me. I always will do molecular and try to see if there is a shared molecular profile. A lot of these will have loss of the CDKN2A. And if it doesn't overtly look malignant, I still often will call these as atypical or a secondary histiocytic neoplasm. Sometimes I'll add this sort of uncertain malignant potential aspect to it, because these are the cases that do worry me that could come back as a malignant histiocytic neoplasm. So we've seen a couple of these case examples with LCH. I've seen ones that originally will look like a very typical xanthogranuloma, and then within a year or less will show up as bona fide histiocytic sarcoma, or look more malignant elsewhere in the body. So just something to keep in mind. So for the malignant histiocytic neoplasms, it's been a long, over 3-year working group that we've been working within the Histiocyte Society with our colleagues from the WHO and ICC groups to really come together and have a set of diagnostic criteria that we sort of all agree on. And it takes a lot for pathologists to agree to everything. So this was recently accepted and should be out for first look in blood this week or next. But we really went through as a group over multiple Zoom calls and looking at 15 plus cases to really say, what are the criteria that we would call malignant in these histiocytic neoplasms. So, the morphology is not specific, and any malignant neoplasm can have these similar nuclear features. But what's important is that you have to first think about these features as well as then starting to roll in with your immunohistochemistry panel. And we wanted to have at least a minimal panel to include for any epithelioid malignant neoplasm to include. And sort of these are the tip of the iceberg. So if one of these are positive, then you should start thinking and adding some other supportive immunohistochemistry and really considering for your pathology lab to bring on Q1. It's one of the only nuclear stained or nuclear markers of histiocytes it's a nice marker to really know that those large malignant cells are positive as compared to cases that have a high intermixed population of reactive histiocytes where the Q1 will be rather highlighting the small intermixed nuclei with negativity in those large malignant cells that are non-histiocytic. So really consider getting that worked up in your lab. Of course, it's also a transcription factor for B cells, so you have to always pair this with other B cell markers along with OCT2 to make sure you're not dealing with a B cell malignancy. Now, other things that seem to be important, the Ki-67, it's still sort of future investigations as to whether mitosis and Ki-67, how much that plays into the diagnosis. And again, when we look at percentage of cell staining, it's not quite defined. I think in the cases with indeterminate, that would probably be the only time if it's really low, longer in expression, less than 5%, to consider it in that grouping. And of course, it's very important to rule out all the other mimickers. Jean-Francois and his group had looked, and I think maybe almost half of their cases that were originally submitted as a histiocytic sarcoma or histiocytic type malignancy were actually not. So it's really important for these undifferentiated cases where nothing is staining except the brown of histiocyte staining, and just to be aware of what cells are really picking up those stains. And then, of course, another big call out for the myeloid sarcomas, especially those that don't have a lot of blast markers, and how to differentiate that because there's two different pathways, of treating. And really, it's important to sample with the blood and marrow, as well as the molecular profiles of these. So this is just our the proposed pathology reporting to sort of understand that this is a large group. Of course, we'll try to subtype when possible, still into the specific criteria, but there are cases where we can't get it into a specific criteria. Again, sort of knowing the molecular is important in these cases. So again, a little schematic to help you and help the pathologists to think about that. So as we end, for some case examples, this was a case of a malignant histiocytic neoplasm, the histiocytic sarcoma type with NF1 and the PTP and 11 mutation. These mutations are actually more common in neoplasms of the bowel. So histiocytic sarcoma of the bowel seem to have this mutation a little more commonly. This was a case of a malignant histiocytic neoplasm occurring after a follicular lymphoma with that Langerhans cell sarcoma type. Langerhans was also positive. And to highlight this Q1, again, nuclear marker, highlighting those malignant larger cells. Another case with the Q1 highlighting the large cells, as well as some background smaller histiocytes that were also positive for CD163. But the interdigitating dendritic cell sarcoma type can be one of the more challenging ones. They typically have more variable S100 staining, but don't often have CD163 expression. So again, having that Q1, of course, the B cell markers in this case were negative, but having that Q1 to highlight those large malignant cells is very helpful. This is another secondary case. This one had really scant, no longer in staining, so fit into that more indeterminate dendritic cell subtype with high expression of CD1A. This was a case that fit more with this newer sort of what we're calling the not otherwise specified category, in which you had these large malignant cells, but they also had both a more macrophage CD163 expression as well as dendritic staining with S100 and longer in. And interestingly, this was a case here from Pittsburgh that had really scant CD1A staining. So really not fitting into a category well at all. So again, more important to get these into a malignant histiocytic category as opposed to trying to subtype it per se. So this is our last case. I'll let you contemplate quietly as what you think is going on here. This is CD163. This is the Q1. It's very high power, but trying to show and highlight that some of these larger cells intermixed are actually negative. So this actually turned out to be a ROS1 rearranged inflammatory myofibroblastic tumor with a lot of intermixed of these histiocytes, and it was these larger malignant cells that were ROS1 positive. So again, a sort of reminder at the end that not all that's CD163 and Q1 brown is an MHN. So you're an expert now going through this. There's a lot of new exciting areas of research and so many questions that we don't know about these groups, but hopefully you're starting to understand the basic categories. It's quite frequent when we're really looking at this to see some of these mixed groups, especially for the BRAF mutated ones, and then understanding the concept of now this more defined grouping of the malignant histiocytic neoplasms. And again, just to remind that it's always a spectrum. The mutation is important, and again, understanding it as a umbrella versus always distinctive entities. So welcome anyone that's interested in coming to Pittsburgh, and thank you for your time. And hopefully now we'll have some open up for questions. Any questions in the chat?
Thank you, Aisha and Jennifer. I see that there are two questions in the chat, and which were already answered. I can ask you something while we wait for everybody to think about possible. Can you comment also on any of you, whoever wants, about phosphoric staining as a possible help in the diagnostic process?
I can comment, and Jen can also, comment. It'll be good to hear from both our experiences. I think phosphoric in isolation, especially when it's diffusely positive in a histiocytic evaluation, I would not consider that as a diagnostic marker of histiocytic neoplasms, but whereas when you combine it with other immunohistochemistry and there is abnormal phenotypes, like with expression of S100 and cyclin D1, OCT2, I think that warrants more investigation by next generation sequencing in integrating the clinical and radiologic presentations as well. While I would say like POC expression in combination with abnormal phenotype is absolutely abnormal, I usually sign out these cases as atypical histiocytic infiltrates. I'm not able to further subclassify into a defined entity, but the pattern of immunohistochemistry present like cyclin D1 diffuse positivity with POC expression is suggestive of MAP kinase pathway activation. But in order to understand if this represents a truly histiocytic neoplasm in a defined entity, they probably need to do NGS and other correlative and follow up. If NGS is negative, clinical staging is negative, and this is an abnormal lesion, I will still place it as atypical because we just don't know what these emerging lesions would present as in future, and essentially have the clinical team monitor it for any new emerging lesions and then reevaluate it on a different biopsy further. Having said that, in a true histiocytic neoplasms, I've seen cases that could be PERK negative yet have an underlying MAPK pathway alterations. I've seen one case of indeterminate dendritic cell histiocytosis with NCOA2 fusion, which can also cause MAP kinase pathway activation, but it was PERK negative and responded great to cobimetinib. So I think our knowledge in this and it's still evolving, and it's not yes or no question is more like a gray zone. So we interpret into context of the other panel of immunostains and findings. Jen, if you want to add more to
Yeah,
PERK.
I mean, I think that the problem with stains is how they're interpreted. And for me, I worked up PERK at my previous institution. I used it frequently, but as was mentioned, it can be a very tricky stain to get working well, and it stains everything. So I've seen people misinterpret it. That's why I typically like cyclin D1. It's an easier stain to interpret. It's readily available. And so, it's always good to have more stains. I think if you're looking to work up a stain in your lab, I definitely would get Q1 and cyclin D1 worked up before PERK, and also knowing that sometimes depending on fixation, if there's no internal control staining, then the PERK didn't work and you can't even interpret it. So you have to know that it can stain everything and it can stain nothing at the same time. So I would never use it in isolation. And I've had a similar experience with LCH cases that were BRAF positive and negative for PERK with the internal control staining, and then they responded well. So I don't know, there's something there. But okay.
Still don't have any questions coming up in the Q&A and also not in the chat.
Okay. Well, thank you all.
Okay. Thank you both so much for really excellent lectures that were very comprehensive and also understandable for the non-pathologists here. And I'm sure that they'll continue to be very helpful when they can be seen on the website. I think we have a closing slide from Kathy. Okay. So we would really like to ask everybody who participated in the session to complete the session survey. It will help us for planning our future virtual events and give us feedback that we will be able to also display after this exit. Thank you again, and we'll be having another webinar in May by this education committee, and the Histiocyte Society would also be very happy to see more members. Thank you.